Hello, everyone. Thank you for joining us here today. I'm Fabiana Bacchini, Executive Director of the Canadian Premature Babies Foundation. CPBF is a charitable organization, and our mission is to empower families of premature babies through support and education. This Preemie Chats series is one of the many initiatives we have to bring information for NICU families and healthcare professionals. Here every Friday, we talk with experts, researchers, and parents who share with us the experience and knowledge. Also on our website, canadianpreemies.org, I'm going to share here the link. We have all kinds of resources and support. One of our programs is the Parent Care Program. CPBF is offering 4 free therapy sessions for families who are currently in an ICU up to 3 years post-discharge. To apply for the Parent Care Program, please visit our website on the resource section, and you'll find all the information there. And today we're going to talk about the preterm kidneys. Babies admitted to the NICU are at a very high risk of acute kidney injury, especially in the very preterm population. Apart from being the organs which filter blood, kidneys act as a versatile system, helping manage salts, fluids, maintaining blood pressure, acid-base balance, and also produce hormones. This presentation is all about neonatal kidney injury in the NICU population. And I have here, join me live from India, actually. I was going to say Vancouver, but she just told me she's actually in India today. Dr. Dr Todurkar, who's a clinical fellow in neonatal perinatal medicine at the University of British Columbia. Currently in her second year of training, she has been appointed as the Chief NICU Fellow. In BC Children's Hospital, she's been part of the Small Baby Project, a quality improvement project to improve care and outcome of preterm babies below 29 weeks. She's also a member of the Nutrition Committee. Her research is focused on the fluid and electrolyte management in the extremely preterm babies in the first few days of life, with emphasis on the kidneys of the neonate. Her areas of interest are neonatal nutrition, fluid management, metabolic diseases, and neurodevelopmental follow-up. She regularly writes blogs related to neonatology for parents on her own personal blog and also for the Canadian Premature Babies Foundation. She also started NewLert, a self-learning group for nurses, which provides up-to-date information on neonatal care. Dr. Todurkar, thank you so much for joining us here today. I know for you, you are almost at midnight, so I'm very grateful that you took the time to talk to us today and really help us to understand the preterm kidneys.
Thank you very much, Fabiana. It's my pleasure. Actually, I'm really honored by being here today. First of all, I would like to thank Fabiana for thinking that I'm capable of telling something to parents, because I'm still a student, and I'm thankful for my hospital, BC Children's Hospital, and which gave me a new perspective to understand neonatology better.
That is wonderful. So I know you have a presentation to share with us. I'm going to start sharing the screen. And for all of you watching us live today on Facebook or YouTube, please do send your questions, your comments. We're going to address them at the end of this presentation. Dr. Todurkar, the floor is yours.
Okay. So today we'll be speaking about the preterm kidneys. I don't have anything to disclose. I'm not associated with any of the pharmaceutical companies, and this is out of my own research and interest. So going to the next slide. Basically, I'll be speaking about why should we discuss about kidneys, who are the babies who are at risk of kidney injury, how is preterm kidney different from those from the kidneys born in a baby who is born at term, why is kidney injury diagnosed less often, and what are the outcomes of kidney injury in NICU. Also, we'll look at long-term outcomes, what are the specific things to monitor after discharge, and the emerging evidence and research in this area. So, why should we talk about kidneys? Overall, worldwide, almost 50% of extremely preterm neonates suffer from kidney injury during NICU stay. Extremely preterm neonates are those less than 28 weeks of gestational age. Depending on various risk factors, the incidence can vary between as low as 18% to as high as 70%. So, because preterm babies are born with way less number of the functional units of kidneys called as nephrons, they are highly susceptible to injury. And if you have had an experience of getting an antenatal consult, you might have noticed that generally neonatologists don't speak much about kidneys. You might have got some information about the lungs, the brain, the gut, the skin, but probably not about kidneys. So I think it is important to speak about kidneys for these reasons. So, if we consider the whole NICU population as such, who is at risk of kidney injury, so irrespective of baby being born preterm or term, those babies who receive IV fluids for more than 3 days, if the quantity of IV fluid is more than 50% of the total fluid intake, for example, if baby is not tolerating feeds or is at risk of infection and then is put on IV fluid for a week or so, those are the babies who are at risk of kidney injury. Also, those babies who are on respiratory support, it can be even a high flow or a CPAP. The reason for this being a risk factor is the kidney is an organ which requires a really significant amount of blood supply and a good oxygen content for proper function. And those babies whose respiration is compromised and who need respiratory support for more than 3 days are at risk of kidney injury. Babies who receive antibiotics for more than 3 days. One of the main reason for that is because the antibiotic themselves are toxic to the kidney cells. And the other reason is that infection or sepsis itself is a high risk factor for kidney injury. All babies who have umbilical arterial line or a lower limb PICC line, they peripherally inserted central catheter can are at risk of kidney injury because these lines can form a clot or thrombus and obstruct these arteries supply to the kidneys, and they can result in kidney injury. So these were the babies who were inherently at risk of kidney injury. But those babies who did not have all these issues, but then get into a risk of kidney injury are those who suffer a major sentinel event or an important event. For example, they develop infection or they have asphyxia during the time of birth, or baby had to undergo ECMO for a very variety of reasons. For example, it could be due to meconium aspiration or pulmonary hypertension. So ECMO is a risk factor for kidney injury. All babies who have suffered from necrotizing enterocolitis, it could be medical or surgical. Medical in the sense babies who were not fed for a while, received IV fluids and antibiotics, and surgical are the ones who have developed clear-cut features of necrotizing enterocolitis and have undergone surgery. So we have already spoken about the nephrotoxic agents or the antibiotics, but apart from that, there are many other medications which can become toxic to kidneys. For example, if baby is on two different antibiotics which are toxic to kidneys and then is undergoing treatment for a PDA, the treatment for PDA is usually an agent which is not helpful for kidneys. So you concomitant use of more than three nephrotoxic agents is a risk factor. Any major surgical procedure puts a baby at risk of kidney injury. PDA, who have PDA as such, which decreases blood supply to the kidneys, and that is one of the risk factor. And upon that, if it is treated medically, the agent used for treatment of PDA is a nephrotoxic drug. Low blood pressures requiring medications is an important risk factor for kidney injury. So we know now that there are so many risk factors for kidney injury, and almost every very small baby can have all these risk factors and multiple risk factors at once. So this is why we need to discuss how is the preterm kidney so much more susceptible to injury than the fully grown baby. So the development of kidney begins at around fifth week and it gets completed by 34 to 36 weeks. So 60% of this development happens during the third trimester. For example, if baby is born at around 24 weeks, then the baby's development of the kidneys is halted during at 24 weeks, and it will take some time for the development to progress. And this very preterm kidney is very susceptible to injury even by very minute risk factors like having respiratory distress syndrome requiring surfactant, some ventilation, and some medications to sustain blood pressure. And just like the brain, the nephrons cannot regenerate once destroyed. And as such, even in normally grown babies, nephron numbers decline naturally over time. But in preterm babies, because they start with very less number of nephrons, that process becomes very significant because they end up with chronic kidney injury earlier compared to their term babies. It has been historically seen that there are a lot of kidney injuries are not being diagnosed. In a survey of multiple centers internationally, in a study called Awaken Study, they have found that some babies had less than three serum creatinine checks in their whole NICU stay. So, serum creatinine is an indirect indicator of the kidney injury as such, and that is probably the most useful biochemical parameter that we have right now. So, the most important reason for not diagnosing kidney injury is probably less awareness among clinicians. Apart from that, serum creatinine, although is useful, is a mysterious chemical because we are not still sure what should be the cutoff for abnormal creatinine values in preterm babies. The values were adopted from the adult population and pediatric population, and it is always very common to see that in the first 1 or 2 days of life the creatinine level are usually very much elevated, and it is a reflection of mom's creatinine level. So even if baby has suffered a kidney injury and baby's creatinine value is high, generally the clinicians might not attribute it to kidney injury as such and might just consider it as mother's creatinine value and a reflection of that in baby's blood. So it is one of the reasons why early diagnosis is delayed. And once creatinine levels become abnormal, it only happens after more than 50% of the kidney's functions have lost. So almost 50% of the damage is already done, and it is a late indicator. Another important factor to diagnose and categorize kidney injury is urine output. So, urine output measurement is a very important indicator and was adopted from adult and pediatric population where urinary catheters are used so frequently. But in preterm babies, urinary catheters are not used frequently, and thus the urine output measurement might be inaccurate, and in many cases it might be mixed with the meconium, and until very late the decreased urine output might not be diagnosed. There is also a physiological response on day 2 or 3, wherein the urine output increases on its own as part of adaptation process, and that might mask the underlying kidney injury. Also, conditions like meningitis or lung problems can cause something called antidiuretic hormone release, which can decrease urine output due to other reasons apart from the kidney injury. So it is really very a complex situation to diagnose decreased urine output, and with the high serum creatinine on day 2, the clinician might not really consider kidney injury first, but actually might consider it as a reflection of mom's creatinine level and might wait for another 1 or 2 days to really uh, point it out that it is probably the kidneys which are not working. So, once kidney injury happens, as I told you, that the nephrons cannot regenerate. Once damaged, they are lost. So, those babies who suffer from kidney injury actually have an increased rate of mortality in the NICU. So, apart from the risk factors which I mentioned earlier, there are other risk factors like if mom is malnourished or had diabetes, had placental insufficiency. Apart from that, baby gets born preterm. All these go on adding up. As you can see in the diagram, the prenatal risk factors with along with preterm birth, NICU course, which is compounded with nephrotoxic agents, various other interventions lead to acute kidney injury. And by early childhood or adolescence, they start developing associated complications. So, in the NICU as such, they suffer from increased mortality and a prolonged hospital stay that could be due to either a damaged kidney itself or due to the after effects of imbalance in fluid management. They generally are not able to excrete enough amount of salts or fluids and have a lot of fluid overload, which can get accumulated in the lungs and then require more ventilation. They can end up with low sodium values or very high potassium levels, which are both detrimental. Their growth is hampered and finally can require dialysis. The long-term outcomes, as seen earlier briefly, are generally chronic kidney failure or chronic kidney disease. So, chronic kidney disease manifests in the form of hypertension or high blood pressures. It can have symptoms like headache, vomiting, confusion, irritability, or can have decreased focus in school, poor school performance. The kidney related long term outcomes are low GFR. Low GFR is nothing but decrease in filtration and more toxins getting accumulated in blood. The membranes can become leaky and proteins can escape from these leaky capillaries in the kidney, leading to albuminuria, and generally they suffer from poor quality of life. In this diagram, we can see that, for example, at 10 years of age, a baby who was born very preterm is at much high risk of chronic kidney disease compared to a baby who was born at full term. Even at 20 years of age or even at 40 years of age, the risk is higher, but they are at very high risk to begin with at in the first week of life to have more and more kidney injury compared to their term counterparts. So, going on to what should we monitor? For example, baby had suffered a kidney injury, probably was diagnosed or probably was not diagnosed, and now is at 2 or 3 years of age and is going to follow. So, what are the things to monitor after discharge? The American Academy of Pediatrics it advises to check blood pressure of babies in all well baby visits in every baby who was admitted to the NICU, and of course in all babies who were born preterm. So one needs to monitor their blood pressure, the growth, the as we noted, the membranes become leaky and proteins can escape in the urine, and this is a very important indicator of progression of kidney disease. So simple dipstick test can be performed on urine samples to check for proteinuria. Kidney function can be checked by checking the serum creatinine level, urea levels, and of course, one has to prevent exposure to nephrotoxic drugs. For example, they get admitted with lung infection or skin infection. One should try not to use nephrotoxic agents in the in the combination of antibiotics which are being used. Also, during the post NICU life, they have to try to avoid obesity, hypertension, smoking, and intake of non-steroidal anti-inflammatory drugs like aspirin or paracetamol or the acetaminophen. So, as the chronic kidney disease can present in late childhood or early adolescence, it is important to know that many kids might remain asymptomatic without any symptoms until they are at the brink of dialysis. Small risk factors or small infections, some stressing factors like dehydration during sports, or some minor surgeries like hernia repair can suddenly tilt the balance to the other, and they can end up with chronic dialysis all of a sudden. So it is very important to keep on checking even though there are no symptoms. So recent research in this area is trying to explore newer biomarkers to detect kidney injury because of all the undesirable features associated with serum creatinine. There are few biomarkers like cystatin C or NGAL which have been very really useful, and they need to be implemented all over with the help of administration and more financial support to institutions. Many major important clinical institutions still use serum creatinine because it is well categorized, and there is good research and literature available for the use of serum creatinine compared to the newer biomarkers. So research is ongoing in this area. During the studies which were trying to see the effect of caffeine on breathing or on apnea of prematurity, the sub-analysis of those studies revealed that the use of caffeine decreased the acute kidney injury, and it is really very fortunate that most of the very preterm babies receive caffeine, and that helps in preventing kidney injury. Once a baby requires dialysis in the NICU, it is a really huge process to get dialysis done because the machines currently available are not suitable for the very small babies, and they usually end up getting peritoneal dialysis. So, smaller machines have been developed for dialysis of very small babies because basically dialysis is a bridging is used to just bridge the time gap between injury and the healing phase of kidneys. And kidneys can heal on their own and start developing some functions while the dialysis is taking care of the clearance of toxins. So, smaller machines for dialysis have been developed. Also, the count of the number of nephrons, or the smallest functioning units of kidneys, was not really available, and a rough guess was around 1 million nephrons in being present at the time of birth in a full-term baby. This was extrapolated from the animal studies, and we were not sure how many nephrons preterm babies have and what is the effect of certain medications on the number of nephrons. So, contrast enhanced special MRIs have been developed to actually count this number of nephrons, which is really remarkable, and I think it is really groundbreaking. It will help us understand how the interventions done in NICU affect the kidneys and how we can better optimize our approach. And also, new definitions and guidelines have been developed. All the definitions of kidney injury, stage 1, stage 2, stage 3, have been adopted from pediatric literature, and we are still not sure how to categorize and classify the kidney injuries in these preterm infants. So I think the need of the hour is that we need better tools to diagnose and treat AKI. For example, on day one, if the creatinine is high and the baby is sick, I think we need better tools to actually see if it is mom's creatinine value or actually the kidneys not working well. Also, we need better tools to diagnose AKI because of the shortcomings of serum creatinine value, and ultrasound is just a rough guide to how the kidney looks, but really cannot see what is happening at a cellular level. And we need to create awareness among clinicians. This is really surprising because generally it is considered that clinicians are they take care of so many different very sick babies, and we need not teach doctors, but it's not really true. And this is evident by a survey done in 2020 of 257 uh, neonatologists and pediatricians. So among them, half of them were neonatologists and half of them were pediatricians. So they completed the survey, and most of them underestimated the risk of acute kidney injury due to various risk factors like prematurity, asphyxia, cardiac surgery, infection, or medications. Less than half of them were aware of the definition according the standard kidney injury definitions, and they were not sure about the current standard criteria for defining neonatal acute kidney injury. So it is obvious that they would not really diagnose these babies. Only half of them were aware of the risk of chronic kidney disease in preterm babies. So, mostly half of them were going to check the blood pressures or the growth or the dipstick urine test or the serum creatinine levels. And only half of them were nearly half of them were unaware of the need to follow up with a pediatric nephrologist. So this is the most striking feature, because even though pediatricians are capable of screening for kidney injuries, it is important that a pediatric nephrologist should be involved in the management of baby who has suffered more than a slight kidney injury. In medical terms, it would be more than stage 2 kidney injury. It is important for a pediatric nephrologist to be involved. So with this, I end my presentations and we can take any questions.
Thank you so much for this presentation and for really teach us about the kidneys. Because you open your presentation about the importance of talk about the kidneys. But my question to you is, why don't we talk about the kidneys in the NICU? Because I spent 5 months in the NICU and I totally forgot kidneys even existed back then.
Yeah, I think traditionally we have been focused on the lungs, the brain, and the gut, which are, of course, very important. And research was also focused on preventing the intraventricular hemorrhage, which can be really devastating. It is like a game changer in a very preterm baby's life. And with the advent of antenatal corticosteroids and the administration of surfactant, the management of lungs were in focus, and more preterm babies started to survive. It is only, I think it is a cultural problem among all the neonatologists who have been not very focused on kidneys, but now it is an important area of concern and emerging research area.
So is this like not area of concern in Canada, or this is what we've seen worldwide? This is not something that is worldwide or is specific to our country here.
It is definitely worldwide. I would say that some hospitals in USA started to investigate in this neonatal kidney injury area, and they found out that the incidence of acute kidney injury is so high when they do the retrospective analysis of baby's chart. But when they look at the discharge summary, it is probably maybe 10% of what actually kidney injuries were had happened, and most of them were not documented or missed, or they had the babies had recovered already. Overall, because documentation in Canada is very up to date, it is possible to do such analysis in USA, Canada, and other advanced economic countries, but in countries who do not have significant resources, they might not have significant tracking of this um, documentation and might be lost to follow up, or their initial blood serum creatinine values might not be available in the electronic system. So I think if it is a worldwide problem, but recognized better in these countries because of better documentation.
Right. So I think my next question to you is, should all babies be screened after discharge? Because from my impression from your presentation, if the baby has the injury, it's pretty evident with the symptoms in the NICU. But for the babies who didn't have any symptoms, didn't have anything in the NICU, should they be screened because of maybe didn't show up in the NICU? Could that show up later in life?
The American Association of Pediatrics advises to screen for growth and for hypertension in all babies who were admitted to NICU, all premature babies, irrespective of how their course was. Related to more detailed evaluation of kidney related parameters, I don't think all babies require such a detailed analysis, and it is as per discretion of their family physician or pediatrician.
Okay, but are pediatricians aware of it in the community?
It is difficult to estimate how many are aware of it. This survey was showing that 50% of them were aware and 50% were not aware. But it is the duty of the discharging hospital to mention the diagnosis in the discharge summary and also convey this message to the following up pediatrician and the family physician. Also, in a severe case of kidney injury, it is important to involve pediatric nephrologist early and also keep them in follow up.
Okay, so we have a comment here from Andrea. Andrea, thanks so much for joining us. It's a great topic. Her daughter had it in an ICU and were actually calling to say goodbye because they didn't think she would make it. Luckily, a new doctor came on shift the next morning and changed all of her meds. The only one I can remember is insulin. He got her peeing and they closed the PGA shortly after that. Andrea, thank you so much for sharing your story with us. Is this common?
I think your baby girl had a significant kidney injury leading to complete shutdown of the kidneys and production of urine. And as the kidneys start healing, they actually have a period of excess urination. So that might look like excess urine output soon after a short period of zero urine output. I think it is very common in term asphyxiated babies who have been cold, who have had therapeutic hypothermia. In very preterm babies, it could be less common compared to term babies. I think the most important thing here is because there was total renal shutdown, it is a quite significant kidney injury and definitely needs follow up because in early childhood or adolescent there can be issues related to kidney damage which has produced a scar because the nephrons do not regenerate again, they produce a scar in the kidneys, and that scar is actually visible on the studies which are performed like the DMSA scans. So these scars also put the baby at risk of urinary tract infections, and they need to be kept under surveillance.
Okay, so when you talk about, we talk about the long-term outcomes, is this the chronic injury is for life or does it ever heal?
Chronic injury is for life.
Okay, so how can parents, I believe so parents will manage according to the severity of the disease during the life course?
It is important to avoid any nephrotoxic agents in future. For example, the antibiotics like gentamicin, vancomycin, amikacin, which are administered very commonly as first-line antibiotics, which was because they're really very effective. But in the background of a kidney injury, they can be just that one hit which is required to tilt the balance towards a baby who cannot really manage their body toxins. Also, it is important to maintain a healthy lifestyle, being well hydrated, preventing obesity, preventing smoking in these susceptible babies, preventing alcohol intake in any type of non-healthy habits.
In other words, having a healthy lifestyle, which is an advice for all of us, right?
Yeah, yeah.
So I had Andrea asked one more question. She missed some of your presentation. What type of follow-up, check for hypertension, creatine, etc. Andrea, we do have the recording. So the record stays on our YouTube channel, also on our Facebook feed, and next month it's going to be on our website as well, just for your information. So maybe you could answer her question, Dr. Todurkar.
Yeah, in case of babies in the initial 1 or 2 years of life, they need more frequent follow-up, at least once in 3 months, and later in life they can be extended to once in 6 months, and then once per year to check their urine protein levels, if their height and weight is growing according to the growth curve or not, and to check their blood pressures.
Okay, that's wonderful. So I'm just want to share your blog here because you have great blog posts also on the Canadian Premature Babies Foundation blog section of the website. You wrote so many great pieces for us, and do you want to talk a little bit about your work as a blogger? What is your goal in terms of educating parents with very specific conditions that show up in babies born preterm?
Yeah, I think I started this blog to put out my experience and to help parents, basically because I was staying in India and I practiced neonatology here, and I found that parents need to know very basic and very specific things compared to just the overall picture. And following my education in Canada, I got a better perspective of how parents are being involved in care of preterm babies, and I wanted to share that with my friends and colleagues. So that was the reason I started writing blogs. But with Canadian Premature Baby Foundation, it is one step ahead, and I can actually speak about how really the different aspects of NICU care is decided based on baby's physiology.
Okay. So we have a comment here from Jessica. She's actually sharing her story of her daughter who had the kidney failure at birth at 24 weeks. Her daughter had a kidney transplant by the time she was 5, and she's now 10 and doing amazing. Thank you for this great presentation. Jessica, thank you so much for sharing your story with us. We're always happy to hear stories of parents, how far their babies have come, and all the things that they overcame because of prematurity. So thank
Yeah,
you for that.
yeah, I think it really summarizes the whole discussion here because it is a classical case of severe kidney injury developing into irreversible condition requiring transplant. Because when Fabiani, you asked me whether it is a chronic, ongoing, lifetime problem or will it ever heal, it is not going to heal. It is a chronic, ongoing problem.
Well, thank you so much for teaching us today, for joining us from India with the crazy time zone that we have. Let me see if there's, I think, one more comment. Oh, Jessica just said thank you to you.
Thank
But
you.
I'm very grateful, Dr. Todurkar, that you always share with us your knowledge, your expertise. We love your blogs, and we have a new blog coming up next week on BPD. So thank you so much. I hope safe travels back to Canada, and I see you soon.
Yeah, thank you for giving me this opportunity.
Thank you. And to all of you watching us here live today on YouTube or Facebook, thank you so much for joining us here today. The video of today's sessions and all the videos from our live series are available on the CPBF website, which is right here, the CanadianPreemies.org. And I want to thank our sponsor, AstraZeneca and Water Wipes, for their ongoing support to our education sessions. And we are a charitable organization, and we believe that through education and support, we can empower families, ensure they're ready to care for their babies. Visit our website, consider making a donation. Together, we can create a brighter future for all our families. And I see you again next Friday, 1 p.m. Eastern Time. Stay well. Thank you.